All right, I will do my best to stay as close to the microphone as possible, but sitting still is not my strong suit. All right, so thank you very much for the opportunity to share a little bit about some of the work that we're doing in our footprint. So I'm going to walk through the first couple of slides pretty quickly just to give you a little bit of context of why we were invited to the conversation. So once we get to those, the biggest thing is Geisinger is an integrated health system. We're located in north central and northeast Pennsylvania, so the upper corner. My home base is in Scranton, Pennsylvania, but we have facilities across that northern tier. In September, we will move statewide, and we will offer our Medicaid products in all 67 counties of Pennsylvania. So pretty excited to see what we've been testing and trying will actually start to move into some more underserved and more rural communities. So as we think about where this work has come from, it was really an intentional move a couple years ago to begin to focus on the whole person. And how do we start to do that? We need to start looking at our social needs, the determinants of health, which all of us are familiar with and aware of. How do we start to learn about those, understand them, and get there? All right, so now can I use, all right. So that's our stats. We'll make sure that everybody gets this. Here's our footprint. Currently, the yellow outline is the areas where we offer health insurance products. The dark blue is where we consider our target core clinical enterprise, and the light blue sections are where patients tend to come from. All right, so this is Jared. This was our move to focus on all of those other things that go into an individual's health. We've all seen the statistic, the 80-20 split, 80% happening someplace else, and impacting on how a person continues their health journey. So we've stayed focused on these four categories, and I'll try to hit on these four categories throughout the entire presentation, but really thinking about how do we get the data that we need? So one of the things that we found is that we first had to ask about food insecurity. So we started asking that question in 2017. We've rolled it across the clinical enterprise. We've interviewed 100,000, over 1 million patients on food insecurity questions. We then developed what's the responses, what does that look like? So it's not enough just to know that they're food insecure, then we start to develop the responses. So gathering that data that isn't just the old stale data that you can have in your publicly available data sets, it really was about how do we create a real living data set that we can respond to. Developing the right community partners is that second phase, and we'll talk a little bit about how we get there, but really finding those with the same core mission and being willing to walk away from the table quickly if somebody doesn't have that same core mission. And so that's one of the things that has really set these initiatives apart. Making sure that we're connecting to the resources. We've developed a social care platform that's available to all of our patients and members. So we have interventions that we can respond to food, but here's others that are available in the community if you're not comfortable coming to us through the healthcare system. And then making sure that we have the outcomes to keep this work going. So social needs screening, we started with the 2 food insecurity questions. In July of last year, we updated that to actually be an urgent need screening. So changing questions to, do you need food this week? So how do we start to address what is the urgent need right in front of us and getting them connected to the resources? So we've screened about 150,000 patients, and you can see there some of the breakdowns. I'll make sure that you get those. Here's the details of our Neighborly platform, neighborlypa.com. We intentionally rolled this out first and made sure that it was available for all of the community organizations to participate and engage in. And now we're able to see how do they engage on the platform, who's reaching out to them, where is the connection starting to come, so we can then prioritize who we're going to reach out to and work with. So really hard to find a picture of levers nowadays. So this is the closest thing that I could get to of the levers in which we're trying to pull multiple levers. So imagine we're all on a beer tasting and we are looking at what are all of the levers that we're going to look at to see which one do we stick with for the rest of the time. All right, so here's a list of some of the community levers. That was creating healthy food guidelines, going out to the United Way and saying, here's those guidelines, we've all agreed to them as a community coalition. will you use them to distribute your funds? And we just cleared the $2 million mark of redistribution of funds. We've supported bringing students in and teaching them about food insecurity. So we have 4,000 students who come into the city of Scranton every year for college. So how do we make sure that they know what the community looks like, that they're now a part of, and then we utilize them to help prepare meals to distribute in the school district. So really trying to make those connections along the way. And then there's those sets of Geisinger levers. And I didn't use the beer tap to introduce this one because that would probably not be appropriate for the health system. But really thinking about that screening for food insecurity, the distribution of food boxes. Yes, we've developed some of those benefits for individuals, but that's not where we're seeing a lot of the value. That's a nice response, but it's not teaching or changing anything about that individual's life. It is really addressing that urgent need. Those are also time limited. So if we don't have a backup plan, it's awesome. We gave you food for here's your 8 weeks of food, then what? And so we're really trying to think about how we redesign that whole system. All the way down to, we've created now and are utilizing a curriculum with our medical students, and then into the piece that I'm going to talk about is the fresh food pharmacy. So you can read the slide, but the short and sweet version of this is, it is a food as medicine initiative in which we took those that screened food insecure, looked at their conditions, and so if you are diabetic with an A1C greater than 8 and screened positive for one of the 2 USDA food insecurity questions, we put those 2 together to automatically generate a referral in the clinical enterprise to a bricks and mortar fresh food pharmacy. So we took a food pantry concept, so the charitable food pantry that we've seen in our communities, we took that model and looked at it, worked with some of the food pantries and said, if you had all the money in the world, what would you really want to do? And so it looks much more like a grocery store with glass front coolers and freezers. It has shelving that is easily accessible. We even have little grocery carts that people can go through and pack their stuff up. And so it really became this place that people could come and engage around food insecurity, which added the dignity component. But now we're starting to think about what else do we need to be able to offer in those environments. So the A1C is that marker that gets you in the door, and there's a couple limitations on age and kidney disease and that kind of stuff, but that's the bulk of it. The unique thing that we've seen is that the program is actually to take care of food insecurity for the household. Because if you take care of just one person in the household, like a medically tailored meal, what's gonna happen to that meal? It's gonna get broken apart and distributed to others in the household that may also need food. And so we put in place 10 meals per week per individual within the household. And they're able to come and get food once a week. Before the pandemic, now we do it every other week, to be able to keep our flows going within each one of those locations. We have 3 bricks and mortar locations. So if you have an extra $1 million laying around, you can stand up and build a facility, a structure, and get it into place with all of the infrastructure. We knew that that was never going to be the sustainable model, but that's where we could start because that's where you can get local philanthropic donations, and that's how we funded this entire project for the last 5 years. It is completely privately funded and through donors, and that was really important for us so that we weren't beholden to any one group or a reimbursement structure in the design. We could really create what we thought was going to be the most impactful. And now we've already looked at and moved this model 3 or 4 times in that we started with the bricks and mortar. And then we're like, we need to think about how we get more individuals. So the entity is actually open, the Fresh Food Pharmacy is open to anybody in the community to refer to. So any provider can refer to the Fresh Food Pharmacy. So it wasn't a Geisinger only kind of thing. So we have some people that have Geisinger insurance, some people that don't. Some people that have a Geisinger PCP and some that don't. So that we could build the systems in place so that flow of information was there for every person who came in touch with the pharmacy. We then opened up the 2 satellite locations, so that was taking the bricks and mortar concept and partnering with an already existing food pantry so that they provide the food and we, the health system, provide the health education, the coaching, the classes, the details that are going to help them work through and really learn what they need to do. And then we've partnered with the food banks in each of the areas. One of the locations is really rural, an old coal mining town. One is a growing Hispanic community, and one is in the city of Scranton, kind of that old Rust Belt kind of revitalizing city, in order to see what it looks like in a couple different places. We're currently in a research project with MIT to look at this. We should have those results by the end of the year, but we've been studying it all along so that we knew we wanted to grow from 1 to 2 to having 3, and now how do we adjust that model? All right, so the things that everybody's interested in, what are the health outcomes that you're starting to see? So across the board, all locations, average reduction in A1C, 2.4 over a 12-month period. That is what we're documenting for everybody who's coming through, which is pretty exciting. One of the downsides that we didn't anticipate is that we were dropping A1Cs too fast, and we were actually sending people to the hospital. And so now we've used that training right at the beginning, that we're adjusting your diet significantly today. So how do you respond to that if you end up having sugar drops and spikes and all of those things, so that, we ended up driving our hospitalizations for the first couple of weeks till we figured that piece out. We've increased our care gap compliance, so we have the identified care gaps that everybody's tracking on HEDIS. We actually show an increased rate of compliance and closure of those compared to all other clinical environments in our footprint. And so that's something that we've been really looking at. How do you use a care team that's designated for this group that is all in one location to really wrap services around? Decreased ED and admissions, LDL, blood pressure, triglyceride, we're seeing all of them go in the right direction. And so what we did was a self-reported study. Let's start asking them the questions similar to Healthy Days, like some of those decisions that you're making. What does that look like for them? And we're seeing an increased self-reporting of all of them. We just hit 1.5 million meals that were distributed through this program. And now we're looking at what else can we do with other disease states to see if we can get the same results. So patient-reported outcomes, the big things there at the top are overall health, and the perception of health for individuals went from 5.7 in the very good category to 30.5 6 months later. And so as we think about what that looks like in people's perception as they get connected to healthy food and get the education that they need, because this is a clinical endeavor, a clinical intervention that really believes in how do we teach people, how do we adjust the systems that they're working in and living in to give them the opportunity to be successful. Frequency of fruits and vegetables eaten before, 17.9, after, a total of over 79% of the individuals were now eating fruits and vegetables on a regular basis. And then the activity levels have also increased. This just gives a breakdown, and you can kind of take a look at this whenever you have a chance, but the number of patients per site where we've started and been working through some of the details. Average family size is about 2.5 across the board based on the size of locations. And then we're seeing those reductions in the A1C. We're seeing the compliance with eye exams, foot exams, blood pressure at goal. Like, we're seeing it across the board, which starts to give us this progressive gap that we've been trying to fill of how do you use this to demonstrate the impact. And we have lots of success stories. This is our first big success story because we also never set it so you ended the program at any time. So this was something where we needed the individual to come to the place where I don't need your help anymore. I think I have all of the pieces that I need. And so we were able to help Rita go through that journey. She's maintained her health and she no longer participates in the program, but comes back and volunteers as a coach for some of the other patients. And then what's on the horizon as we keep thinking about this? Really, it is that Fresh Food Pharmacy Lite, the satellite option, and how do you partner with existing community organizations? We've created a digital app in which not only available to the individuals, we're now working on how do we get technology in all of their hands and have an initiative going right now to make sure we get everybody connected in that way. Of course, the challenges that we face are funding. How do we make sure that we have the sustainability? That's why we need those results, because healthcare doesn't start paying for anything until you pay the millions of dollars to study it. And so we're doing that study to be able to have those results to start to inform what the system looks like. So I think the next thing, what does it take? So really it was about telling people and helping them to understand the why. Why are we doing this? What's the meaning behind all of it? And as I look over the things that became really important to us was, what does that whole person orientation look like? How do we change the training of medical professionals in our community? So how do we start to teach food as medicine? How do we change the curriculum at the medical school so that these conversations make sense? And then making that decision that it's really beyond filling a belly to how do we create healthy foods that are sustainable, and then removing that stigma. If one of those lessons that we've learned is that everybody was willing to go get food during the pandemic because it was mass distribution. The environments were very different. It was less of a you show up and walk into a facility versus you're able to participate just like everybody else. And so how do we start to get that same method of distribution as we move forward? Engaging the leadership, designing the intervention, really thinking about how you design it from the beginning. So we designed it as a clinical intervention. That was the purpose, because we knew as a health system we can't continue to sustain the, oh, that feels good to do. We needed to figure out how do we link this directly to the health outcomes. Making sure that the CBOs are at the table and ready to participate, that we start something and give it a try. We knew that we were gonna need to make adjustments, but we made sure we built out that data collection at the beginning, had the dashboards everybody was watching, and then we could make these adjustments along the way because we could track what was happening with each one of those modifications. Then navigating the patients, how do you work with them to go through this new journey and evaluating your efforts? Because I think what this gets us is a new type of medicine that we're all gonna be working on. This is the way that we start to move us into a conversation around, it really is the food that is going to give us the entry into the conversations of our community. Nobody's gonna be opposed to you making healthy food available to a teenager or to a kid or to a family. And so even the people that don't like us in the conversations, the ones that we've tried to purchase or we raise their insurance cost or whatever reason, they were still willing to come to that conversation because it's all of these things that are gonna start to help us change this and make food really become part of what we should expect everybody to have access to every day. Thank you.
So I'm Lisa. You can call me Roberson because honestly, English dictates that it should be pronounced Roberson, although I was informed by my husband that I'll have a lifelong comments on how to pronounce it as Roberson. Something went wrong there for sure. I'm a registered dietitian, and I have been working with a healthcare food service company for many years, over 20 years, which is interesting to note. It's because I haven't achieved my goals, so I may be working for this company for another 20 more years until we actually make sure that we incorporate wellness, sustainability, and now my new favorite word, nutrition security, thanks to Anne, into our organizational structure. So I have no conflicts, but I do work for Compass Group. It's a for-profit organization. And I also work in the private sector primarily, so I have a little bit of a different perspective. So I want to tell you a little bit about Compass Group and our reach. We are a global company. I work in the Compass Group North America entity. We represent $20 billion of business in healthcare. We serve 99 of the Fortune 100 companies. We have 28 sectors and subsectors. I work in the specialized sector, as Dr. Sanchez mentioned, for healthcare. And we have a lot of different moving parts, but in Morrison Healthcare in particular, I work with almost 1,000 hospitals nationwide. So I only work with hospitals that are focused on wellness and sustainability change. So when you look at that, that's about 25,000 associates that work with us. We serve 600 million meals annually. That's a lot of opportunity to make change. And when I think about that every day, that's what gets me into my pants every day and going back to the grind, and it's not always easy. We have a almost 99% client retention rate. And I think that's something that's worth noting, that people in healthcare still come back to us looking for good solutions. We work with Practice Green Health, and I know I saw somebody on the participant list is from Partnership for a Healthier America, and we are lifelong, partners through Partnership for a Healthier America. That was a great way to change and transform our business. Here's some of the partners that we work with, some of our main strategic partners. I'm going to share a few of their examples. So I'm going to come to you from the perspective of the food environment for employees and patients in healthcare. And I'm going to share some examples from some of our partners, because we're talking about nutrition security and how do we make change? How are we impacted? So I thought I'd just go ahead and dive into the opportunities and barriers, and I just laid it out. And then when Dr. Sanchez kicks me off is when I'll stop showing the examples. But when we look at the opportunities in healthcare, food environments, the number one is that transforming hospital food service to healthy food environments is an absolute must if you want to lead in healthcare. And I have a lot of hospitals coming to me and say, I want to be the leader in healthcare. I want to be the healthiest hospital. Mayo Clinic and Cleveland Clinic are both programs that work with me, and I've had the privilege of helping guide and develop their food philosophies and guidance over the last several years. Please don't tell each other that I've done that with each other. We don't recognize each other when we have our conversations. But when we think about healthcare facilities looking for upstream solutions to improve nutrition security and addressing social determinants of health and population health, you cannot do that unless you begin with changing your own food culture first. And that is an absolute must. And it's harder than it looks. It really is. So the number two opportunity that I see in the healthcare space, one of the things I've learned from our clients is that the best healthy hospital innovators, they actually create the solutions that make healthy eating easy for their staff, patients, and community. And I did not coordinate with Brian, but he just gave an outstanding example of that fact, is that he's had to go out, his team, Geisinger has had to go out and put their stake in the ground and make it happen. And unfortunately, that does not translate to easy when you are a healthcare system. So that is something that we most certainly have to consider, and the most motivated are the ones that will make change. And when you look at what these solutions are as far as innovation, we are already seeing robotics, artificial intelligence, tech-based solutions. Those are the only ways we can actually keep staff and food service operations running right now with the labor shortages that we've had. Plant-forward meal options are huge right now. Dr. Sanchez mentioned the Eat Lancet. There's 96 pages all about that topic and why it's so important to individual health and planetary health. And then meal delivery and meal kits, medically tailored meals. We've heard that brought up by Dr. Thorndike. Gardens, food pantries, and produce prescriptions, and then always making sure that there are sustainable solutions to everything. So the best healthy hospital innovators also execute what I call the 3 E's. You've probably heard this in many ways, shapes, and forms, but we need to include, they understand the value of education and include engaging ways to change behavior. I don't know what it is, but we talk about marketing, and I'd love to talk to Dr. Thorndike about that, about targeted marketing, and I think about YouTube and TikTok and all of the ways that our children today and us, ourselves included, learn about the world, and is there opportunities to change that for good? Most of the kids, I'm a dietitian, most everybody I know has learned nutrition from YouTube, not from any lecture I have ever given, but they've learned it from YouTube. But I just validate that for them. So finding ways to change how we approach engagement. Culinary medicine is huge right now. Teaching kitchens were a thing before COVID sort of took them off the grid. Using brands that people recognize, HelloFresh as a meal kit, but putting it into a way that makes sense. Even when we were talking about produce, Dr. Thorndike was addressing produce. I can tell you with sales, if we put grapes in a bag and it's sealed up and packaged and we sell them at a decent price, they sell versus an apple or a banana. It's just the reality of how we think about convenience and how we look at food. And in a small way, fresh food has been unadulterated. We've left it untouched, unprocessed. And I see in the retail spaces in healthcare, it's not working that way. We have to kind of make it into the mainstream item that people really, really want and crave. So that's part of it. So what are the barriers? I'm just going to jump to the barriers right now, and then I'm going to show you a few examples. What stalls progress or limits success that I've seen most often than not is actually unified buy-in from hospital leadership, and then also lockstep partnership and execution. If one of these two components are off, your program never gets off the ground. And what I mean, so I work from the healthcare food service side. So if my Mayo Clinic director says, I want this to happen, we're partnerships. We sit in a room, we do a retreat, we have a table, we all put our ideas out there, we agree on milestones, we make change, we make it happen. If I have a partner that says, I want you to do this, just make healthy eating, and then walks away and attends to other things and never comes back, it never gets off the ground. And this is so critical. So we all say we want to do it, but we actually have to do it if we want to make change. And then, I think lack of good ROI studies or outcomes often make investment a barrier to change. I've sat in the C-suite so many times, and people are saying, well, just show me how I'm going to get my money back. I just want to know, how am I actually going to get my dollars back? And I can bring all kinds of concept models and studies that suggest that you're still going to have better outcomes, but I can't always prove that I can put the money back into your account. And so that barrier becomes so dramatic. And then the third is payers who will fund nutrition programs. The best nutrition programs, and hopefully I'll get a chance to show you Boston Medical's program, the best programs are self-funded through philanthropic means, just like Brian had mentioned, which is interesting. Everyone is self-funding. And while I feel like that's a great thing, and on the one hand, I also feel that it's very easy. I can go get a prescription, right, for maybe a lesser popular insulin for $5. Right now at Kroger. I don't know, maybe Dr. Watkins at Kroger. He's like, yes. So, how do we make food and nutrition programs that easy? And when we can do that, that'll change this whole opportunity here. So I'm going to share with you a few slides from Mayo Clinic. They have a crossroad between food philosophy and sustainability strategies. I'm going to talk a little bit about their food philosophy. We helped design their food philosophy, and it was centered around this: limiting foods known to cause disease and increase foods that support health. And we created this action plan strategy for like 2 years about reducing processed meats, because you couldn't just go in and take out the bacon. Seems so easy, right? But so instead what we started with was hot dogs. So we said, hey, we already know, AMA has already said it, take those 5,000 hot dogs off the map. But then you can see what we've had to do. First step, soups containing bacon or ham, replacing lunch and dinner entrees. We thought about putting public health service messages out there. I really think they would have worked, but administration said no, kind of the disincentivizing. Reducing sugar was another component of this, reducing fried foods across the organization. When we eliminated fryers at Mayo Clinic, it was literally the equivalent of 14,000 gallons of oil, which can fill a 14 by 28 foot pool 5 feet deep with oil. So it's crazy what you think about. We created plant-based concepts. These are concepts through MORRISON Healthcare. We have a series of Five Guys, except it's like carrot greens, it's beetroot, it's Collie Club and Silver Kings. It's all with a singular produce ingredient that's at the core, and it's made 5 ways. And it's extremely popular, not as popular as we'd like, but we're moving in the right direction. And here's the innovation. This is, some people, you may know it as Sally the salad robot, but we don't call it Sally. It's gender neutral. It's just salad guy. Well, salad person, I guess. So anyways, they also introduce healthy deals to help incentivize those items that are healthy. And when we looked at what we've done in the area of plant-based menu concepts, I mean, in just 17 months, we've made tremendous progress on actual quantities sold of these items. So it takes a village. Quickly, SUNY Upstate, same thing, labeling. We have some labeling for vegan, fit, vegetarian options. We were able to make that change. Here's the register. You can see after some of the changes that we've made. And when we looked at were people really going for this, if you look at the bottom, the pre-menu and post-menu changes, you can see that there was a almost 5 to 6% variance, which in healthcare, in food service sales and healthcare is huge. If you've made a 1.5% increase in sales, you've done it. So this was tremendous. It just shows that the populations are really, really wanting this. And the last but not least is this is Boston Medical Center. And this is, they have what I call the trifecta. It's the rooftop farm and pantry. They have a food pantry. It's a clinic. People come in one way. It looks like a medical clinic. They come out the back way. It protects dignity. It's a fantastic use of not only the rooftop farm goods, but also it's subsidized through the food pantry. And they have a teaching kitchen that helps instruct what to do with all of these items as well. So we're seeing more and more requests for farm to bedside, farm to cafe, farm to table in each of our hospitals. It's been really tremendous. So I am actually going to pause right there and we'll go ahead and transition.
Thank you so much.
Hi, everyone. I'm delighted to join you today remotely and appreciate the opportunity to learn more about your work. Liz Fowler, who, as you may know, is both the director of the CMS Innovation Center and the CMS Deputy Administrator, is very sorry her schedule didn't allow her to be here personally today, but she asked that I convey her strong interest in your work. Liz and the entire leadership at the Innovation Center share the urgency of the goal to better meet the food and nutritional needs of all Americans, including Medicare and Medicaid beneficiaries, and particularly for underserved communities. And we are very interested in understanding the possible synergies between your work and ours. Our priorities are to ensure that our work increasingly and fully reaches underserved communities, that is focused on beneficiaries and meeting them where they are in their homes and communities, that it is measurable, and that we seek out partnerships in alignment with a broad range of stakeholders. Now, before diving in, I want to put out my favorite slide here, our disclaimer that my goal here today is for educational purposes and general information sharing, as noted here. So with that, I'd like to talk to you this morning about the work that the CMS Innovation Center is doing related to food as medicine and nutritional and food security, and our focus on health equity and reducing disparities that reaches across HHS, CMS, and the Innovation Center. Importantly, these priorities set the stage for addressing health and health-related social needs for underserved communities, including, importantly, food and nutritional security. For today's agenda, I'm going to talk a little about 3 such models within the center, before diving in a bit more into the value-based insurance design, or VBID model. These models, as shown here, have been made possible by the authorities to the Innovation Center. For those who may not be familiar with the CMS Innovation Center, these authorities that were created by the ACA allow us to test interventions that would otherwise not be allowed within CMS by waiving certain regulations, giving us a platform to innovate, to test new interventions, and to develop the evidence to support expansion more broadly across CMS. One of the challenges that we have is to develop the data that will allow us to optimize what and how we meet health-related social needs, and to demonstrate the impact on health outcomes on patient experience and on the return for investment in these areas. But before we jump in, I wanted to start by recognizing that the work that you do each day and recognize the work that you do for finding ways throughout the pandemic and beyond to nourish your beneficiaries, communities, families, and friends. And I would also like to recognize the pivotal role our provider, community, and payer partners in building out the programs at the Innovation Center that I'll tell you more about in just a few minutes that are reaching underserved communities and meeting social needs, including food and nutritional needs. The Innovation Center leadership sees growing partnership with payers, community-based organizations, and health and business leaders as essential to our work, and was one of the reasons that we've been so enthusiastic about being represented here today. So now I'm going to turn over to tell you a little bit more about these three models within the center that enable a special focus on meeting social needs by partnering with communities, providers, and our payers. So the first model I want to tell you a little bit more about is our Accountable Health Communities model. So over a 5-year period, this model provided support to community bridge organizations to test promising service delivery approaches aimed at identifying health-related social needs and linking beneficiaries with community services for housing instability, food insecurity, utility needs, interpersonal violence, and transportation needs. Our model participants in this model use the publicly available AHC health-related social needs screening tool to assess for those health-related social needs that I had mentioned. And as you can imagine, food insecurity was the most commonly reported health-related social need among navigation-eligible beneficiaries in pretty much all bridge organizations. And again, as you can imagine, throughout the COVID-19 public health emergency, our model participants identified even higher levels of need when it comes to food insecurity, especially from families affected by loss of work and lack of access to pantries and shelters. And to meet this higher level of need, our model participants expanded their offerings, bringing together CBOs or community-based organizations and food providers across multiple locations while coming up with systems to track food insecurity orders, such as an electronic medical record, so that we could keep a centralized work queue for physicians to document what their patients' food needs were. And there are so many other really important lessons learned from the AHC model that we're unpacking currently to help inform future directions. And speaking about future directions, one such model is our ACO REACH model, which was recently announced. And this model is focused on using innovative payment approaches to better support care delivery and coordination for patients in underserved communities. And this model specifically requires that all model participants, and I think this is a trend that you'll continue to see out of CMS Innovation Center models, is that the model participants develop and implement robust health equity plans to identify underserved communities and implement initiatives such as the ones that we're speaking about today around food insecurity to measurably reduce those health disparities and health-related social needs within their beneficiary populations. One really, I think, novel piece about ACO REACH is that we offer flexibility to model participants and their providers to offer in-kind incentives such as access to meal programs for their members with malnutrition needs through what are called beneficiary engagement incentives. And we hope to see continued uptick in these offerings. And while ACO REACH will begin in 2023, a model that's been around for some time is the Value-Based Insurance Design, or VBID model. So to provide you with a high-level overview, the VBID model has a broad array of complementary Medicare Advantage, or MA, health plan innovations, or what we like to call programmatic flexibilities. And as similar to our other two models, the VBID model has the goal of reducing program expenditures while importantly improving the quality of care for Medicare beneficiaries, including low-income beneficiaries. And through important partnerships with our participating Medicare Advantage organizations, or MAOs, the VBID model is providing the flexibility for plans to deliver and test a vast range of additional benefits addressing their member clinical, social, and functional needs. For example, the VBID model flexibility to target benefits to members based on their clinical and or social needs allows MAOs to focus and tailor their benefit flexibilities where they're needed the most in underserved low-income populations. And since the model first started in 2017, as you can see here, we've seen quite a bit of uptake in the model. From 45 plans when we first started in its original model design, which was more limited in scope versus the transformed model in 2020, and how that revised, what we call VBID 2.0, has seen an uptick over the last 3 years to more than 1,000 plans participating in 2022. And what this number translates to is an increase in the number and types of clinical and social needs focused interventions, and importantly, their reach to over what we project over 3.7 million enrollees projected to receive model benefits in 2022. And a really big focus of the interventions being offered in 2022, of the 3.7 million enrollees, 3 million are projected to receive healthy food related benefits through the model itself. So when we're talking about VBID, as I had mentioned, VBID is sort of a vehicle that we have to test lots of different MA flexibilities, and some of them are shown here on the left. So one of the flexibilities that we have, we allow health plans again to target their benefits to those who have the most need or where the benefit is most appropriate for that beneficiary. And so one mechanism that plans have under the VBID model is to target their supplemental benefit offerings or reduce cost sharing to, say, members with low-income subsidies or by, say, chronic condition. And so an example, what does this tangibly look like, or how does it align with what we're talking about here today around innovative food and nutrition benefits and interventions? Plans could offer a healthy food card or medically tailored meals specifically to enrollees with a low-income subsidy status or with hypertension to really ensure that those targeted enrollees facing food insecurity those needs are being addressed directly. Another component of the model is what we call rewards and incentives programs. So through such a R&I, or reward and incentive program, a health plan could, say, provide a reward of $100 in healthy groceries to incentivize the utilization of high-value services, say, by a certified nutrition specialist or enrollees with low-income subsidies with, say, pre-diabetes. And that could be complemented with other VBID interventions like removing barriers to access to go and see a certified nutrition specialist by removing the cost sharing that might be associated with that visit. And that could be even further wrapped around with additional benefits through the VBID model, such as covering new and existing technologies or FDA-approved medical devices like coverage of a blood pressure cuff or monitor or cuff or continuous glucose monitors. So you can see sort of how the suite of interventions could come together to address the food and nutrition needs of an individual as well as wraparound needs as well. And before I wrap, very similar to one of the speakers before me, I want to make VBID a bit more tangible by sharing the story of a beneficiary, Rosa. Rosa has pre-diabetes and recently began taking metformin. She receives low-income subsidies, struggles to afford healthy food, and can't access a few grocery stores nearby due to transportation limitations. She recently joined a VBID plan that's offering a healthy food card, eliminates Part D cost sharing, including for metformin, and trips to the grocery store and pharmacy. And this was possible for the plan through VBID's LIS targeting. And such comprehensive social needs benefits may not have been economically feasible if the plan couldn't target by socioeconomic status. And as a result, here in this illustration, Rosa's not only been able to access her needed medications, but also healthy foods, addressing both her medical and social needs. And so if we take a step back, there are thousands of other Rosas out there that these types of interventions would help and do help today through the VBID model. These benefits, like access to healthy foods, can not only help improve quality of care, but also make beneficiaries feel like they have more agency over their health and address social needs for some of the most underserved communities within Medicare. And taking one more step back, as you can tell, there are many opportunities across CMMI's portfolio of work to nest interventions to address food insecurity within our models, such as the VBID model or AC or REACH or the HC model. And I think that shows that this work is even more important as we continue our focus on advancing health equity, that we don't just have one model, but this is nested within everything that we do within the center. And with that, I'll wrap and thank you all for your time this morning.